In this video, we will discuss about the anti-diabetic medications used in type 2 diabetes. Let us first take a look at the group of drugs which will be discussed in this video. We have sulfonylureas, meglitide analog, D-phenylalanine derivative, two of which are also called glinides, which act by increasing the secretion of insulin from beta cells of pancreas, who are called as insulin secretagogues. The glucagon-like peptide 1 agonist and the dipeptidyl peptidase 4 inhibitors are also insulin secretagogues but act through incretin mechanism. Biguanides and thiazolidinidines are the two groups which act by increasing the insulin sensitivity in various tissues. We also have drugs which inhibit the alpha-glucosidase enzyme present in the cross-border epithelium of small intestine and delay the carbohydrate absorption. We have a drug named pramlintide, which is a synthetic analog of amylin secreted by pancreatic beta cells. Bromocriptine has agonistic action on dopaminergic system of our body. And we have inhibitors of sodium glucose link transporter 2 on renal tubular cells, which increase the excretion of glucose in urine. A bile acid sequestrant, colesevelam, is also approved for use in type 2 diabetes. Now let us look at how these insulin secretagogues act. The beta cell of pancreas has got a ATP sensitive potassium channel which transports potassium out from the beta cells. After we take meal, the GLUT2 mediated uptake of glucose into the beta cells and its subsequent oxidation to form ATP or the use of sulfonylureas and glinides can block this ATP sensitive potassium channel, resulting in increased concentration of potassium inside the cells. This results in membrane depolarization and opening of voltage mediated calcium channel in the cell. This causes calcium influx into the cell, which mediates exocytosis of insulin filled vesicles out from the beta cells and subsequent release of insulin from the cell. Incretins, on the other hand, act through G-protein coupled receptor. Beta cells of pancreas have G-stimulatory form of G-protein coupled receptor, which on stimulation causes the stimulation of adenylate cyclase and results in increased level of CAMP in the cells. This CAMP also helps in exocytosis of insulin-filled vesicles out from the cell. Now let us look at sulfonylureas in detail. In addition to increasing insulin secretion, this sulfonylurea also decreases serum glucagon level, most probably due to enhanced release of both insulin and somatostatin, which inhibit alpha cell secretion. The first generation sulfonylurea includes tolbutamide, which is a short-acting agent with elimination half-life of 4 to 5 hours. Due to its short half-life, it is safest sulfonylurea for elderly patients. Fluorpropamide is longer-acting first generation sulfonylurea with half-life of around 32 hours and is metabolized in liver to active product, so it has longer duration of action and can cause prolonged hypoglycemic reaction. Glyburide is a second generation sulfonylurea which is metabolized in liver into active product. It has short half-life but acts for longer period due to its active metabolite. Glipizide has shortest half-life of around 2 to 4 hours. Due to its shorter half-life, it is less likely to cause severe hypoglycemia. Limepiride is a longer-acting second generation sulfonylurea which is approved for once daily use as monotherapy or in combination with insulin. The most common adverse effect of these agents is hypoglycemia. The elderly patients and the patients with renal and hepatic impairment have more risk of serious hypoglycemia, so these drugs are not used in those groups. Gastrointestinal disturbances like nausea, vomiting, and diarrhea can occur with these agents. These are sulfur-containing compounds, so hypersensitivity reactions can occur with these agents. So these drugs are contraindicated in sulfur allergic patients. A hyperemic flush with alcohol use, dilutional hyponatremia, cholestatic jaundice have occurred, especially with chlorpromamide. Their safety has not been established in pregnancy, and all of these agents are secreted in milk. So these drugs are contraindicated in pregnant women and lactating women. Now let us look at other insulin secretagogues. Repaglinide is a meglitinide analog and napaglinide is a diphenylalanine derivative. As we have already discussed, this drug acts by closing ATP sensitive potassium channel and increasing the insulin from beta cells. These drugs have fast onset and they are shorter lasting than sulfonylureas. So when taken about 10 minutes before meal, this drug effectively controls postprandial hyperglycemia. Napaglinide is more safer than repaglinide in patients with renal or hepatic impairment. These drugs have no sulfur group in their structure, so can be given in patients with sulfonylurea allergy. Now let's look at the drugs acting through incretin mechanism. Incretins are gastrointestinal hormones secreted by the intestinal cell after we take meal. Glucagon-like peptide 1 and glucose-dependent insulinotropic peptide or gastric inhibitory peptides are two notable incretins. These incretins enhance insulin release, suppress glucagon release, slow down the gastric emptying, and cause central loss of appetite by activating glucagon-like peptide 1 receptors, which are G-protein coupled receptors expressed on cell surface of beta cells, alpha cells of pancreas, neurons, and gastrointestinal mucosa. These incretins are rapidly degraded endogenously by the enzyme dipeptidyl peptidase 4 (DPP4), which is expressed on the luminal membrane of capillary endothelial cells, kidney, liver, GI mucosa, and immune cells. So we have drugs like GLP-1 receptor agonist, which mimic the action of GLP-1, and DPP4 antagonist, which antagonize the degrading enzymes and increase the action of GLP-1. Exenatide and liraglutide are two GLP-1 receptor agonists currently in use. Exenatide has a half-life of 2 hours, it acts for around 10 hours and is given subcutaneously 1 hour before meal twice daily. Whereas liraglutide has a half-life of around 10 hours, works for around 24 hours, so is suitable for once daily dosing. Both of these drugs are injected subcutaneously. Nausea, vomiting, and diarrhea are the most common adverse events encountered with these agents. Pancreatitis has occurred with both of these agents, and hypoglycemia is rare with monotherapy, but can occur when combined with other insulin secretagogues. Liraglutide is contraindicated in patients with personal or family history of medullary thyroid cancer, multiple endocrine neoplasia type 2. Dipeptidyl peptidase 4 inhibitors or the gliptins include sitagliptin, linagliptin, and sitagliptin, which are orally available medications and are approved for use as monotherapy with diet and exercise and in combination with metformin, sulfonylureas, and thiazolidine agents. Hypoglycemia has occurred when combined with sulfonylurea, and peripheral edema has occurred when combined with glucagon. Hypersensitivity reactions have occurred with these agents, and pancreatitis has occurred with sitagliptin. These drugs should be immediately discontinued if pancreatitis or allergic reactions occur. Headache and upper respiratory tract infection are the most common adverse effects encountered with these agents. These drugs are largely excreted unchanged in urine, so dose reduction is needed in patients with renal insufficiency. Hepatotoxicity has occurred with vildagliptin, so dose reduction in hepatic insufficiency is needed in case of this drug. Biguanides are the insulin sensitizers. Metformin is currently the most commonly used oral agent to treat type 2 diabetes and is accepted as the first-line treatment for this condition. Another agent, fenformin, has been discontinued because of its association with lactic acidosis and no proven long-term benefit from its use. This metformin activates AMP-dependent protein kinase most possibly by reducing intracellular energy stores. This activated AMP kinase reduces the gluconeogenesis and lipogenesis, whereas it stimulates fatty acid oxidation and non-oxidative metabolism. It also stimulates glucose uptake. The net result of these actions is increased glycogen storage in skeletal muscle and increased insulin sensitivity. Whereas decreased rate of hepatic glucose production and lower blood glucose levels. Biguanides have several advantages, like they are non-hypoglycemic, they do not increase weight gain, and they have insulin-sparing action, so they do not accelerate beta cell absorption or failure in type 2 diabetes. They decrease the risk of both macrovascular as well as microvascular complication of diabetes, in contrast to other therapies with only modified microvascular morbidity. These agents can be used as monotherapy or in combination with secretagogues or thiazolidinediones. Metformin is also efficacious in preventing the new onset of type 2 diabetes in middle-aged obese prediabetes. The most common adverse effects of these agents are anorexia, nausea, vomiting, diarrhea, and abdominal discomfort. Reduced blood level of vitamin B12 has been associated with use of metformin, probably due to its malabsorption. Lactic acidosis has also occurred with metformin, so it is contraindicated in patients with severe renal and hepatic disease, chronic alcoholism, and heart failure, as well as other concurrent conditions that can cause poor tissue cohesion.
Another group which act by increasing the insulin sensitivity are thiazolidinediones. Thioglitazone and rosiglitazone are two drugs under this group. These are the ligands for peroxisome proliferator activated receptor gamma (PPAR gamma), which are a group of nuclear receptors expressed primarily in adipocytes and muscles and liver cells. When these ligands bind to this receptor, it forms a heterodimer with retinoid X receptor and interact with PPAR response element on genes involved in lipid and glucose metabolism, insulin signal transduction, adipocyte and other tissue differentiation. The overall action shown by these agents is increase the insulin sensitivity and increase the glucose uptake into adipocytes. Pioglitazone has PPAR alpha activity as well, so it also lowers the triglyceride level and increases the HDL level. The main adverse effects with this group are peripheral edema, weight gain, osteoporosis and increased risk of bone fractures and congestive heart failure. Rosiglitazone has been withdrawn due to unacceptable increase in risk of myocardial infarction, congestive heart failure, and stroke. These drugs are contraindicated in presence of hepatic disease, heart failure, and pregnancy. Alpha-glucosidases are the enzymes present in broad border of intestinal cell which are involved in digestion of starch and disaccharides. Inhibiting this enzyme, maximal digestion and absorption of ingested starch and disaccharides are delayed, and this effect is shown by agents like acarbose and miglitol with similar effects, except miglitol has more potent action while inhibiting sucrase enzyme. These agents are taken at the beginning of each meal. The adverse reactions shown by these agents include the GI disturbances like flatulence, diarrhea, and abdominal discomfort. Hypoglycemia can occur with concurrent sulfonylurea treatment. Treatment of hypoglycemia should be simple glucose, not sucrose. These drugs are contraindicated in inflammatory bowel disease and renal impairment. They should be used with caution in hepatic impairment. A STOP NIGDM trial shows alpha-glucosidase therapy has prevented new diabetes in pre-diabetics. It helped to restore beta cell function and reduce the cardiovascular morbidities in diabetes. Amylin or islet amyloid polypeptide is secreted by beta cells of pancreas along with insulin. Pramlintide is a synthetic analog of amylin. These amylins reduce the glucagon release. delay gastric emptying, and promote satiety, most possibly by acting through amylin receptors present in brain. Weight loss is an added benefit. Pramlintide is subcutaneously injected immediately before meal and administered in addition to insulin in patients unable to achieve target postprandial blood glucose level. Hypoglycemia and nausea are the specific side effects of pramlintide, and it is contraindicated in GI motility disorders. Bromocriptine is a dopamine agonist and is approved for use in treatment of type 2 diabetes. It is thought to act on the circadian neuronal activities in the hypothalamus to reset an abnormally elevated hypothalamic drive for increased plasma glucose, free fatty acids, and triglyceride level in insulin-resistant patients. A quick-release formulation of bromocriptine administered in morning is believed to augment low hypothalamic dopamine levels and inhibit excessive sympathetic tone within the central nervous system, resulting in reduction in post-meal plasma glucose levels due to enhanced suppression of hepatic glucose production. Sodium glucose link transporter 2 inhibitors like canagliflozin and dapagliflozin are also approved for use in type 2 diabetes. In the proximal tubular cell of renal tubule, the sodium-potassium ATPase pump in the basolateral site of the tubular cell transports sodium out into the interstitium and potassium into the tubular cell and maintains a concentration gradient. Based on this concentration gradient, the sodium-glucose link transporter 2 transports sodium and glucose into the tubular cell from the renal tubule. The sodium-glucose link transporter 2 inhibitors inhibit this channel, and the glucose is retained in the renal tubule, which is then excreted in the urine. So these agents reduce the blood glucose level by increasing the excretion of glucose in urine. The adverse effects of these agents are related to this mechanism of action, like increased incidence of urinary and genital infections, electrolyte imbalance, and increased urinary frequency. Colesevelam is a bile acid sequestrant approved for use in type 2 diabetes. The exact mechanism of action is unknown, but is presumed to involve an interruption of enterohepatic circulation and a decrease in farnesoid X receptor activation. Farnesoid X receptor is a nuclear receptor with multiple effects on cholesterol, glucose, and bile acid metabolism. Additionally, the drug may impair glucose absorption. The side effects of this drug include gastrointestinal complex like constipation, indigestion, and flatulence. These medications impair the absorption of bile salts, which are necessary for fat and fat-soluble vitamins absorption. So, reduced absorption of fat-soluble vitamins have been seen with these agents.
Thanks for watching. Subscribe the channel for more videos.